Hello, everyone, dear guests and panelists. We are going to discuss now about a very crucial issue that has not been discussed as extensively as it should have for many, many years. The bioethics concerning the smoker's right on credible information. So it's not a strictly bioethical approach in terms of non-maleficence, beneficence, and all the other principles of bioethics. But we are going to discuss about science communication, about information, what smokers should and do know. So I'm honored to have as members of this panel, first of all, Professor Panagiotis Bamidis, who is a professor of medical physics, medical informatics, and medical education in Aristotle University of Thessaloniki in Greece. He designs, implements, and evaluates IT and assistive technology systems that improve either daily lives of elderly and other sensitive groups or education and training of healthcare professionals. He performs a lot of research on, to understand how the brain reacts to different stimuli, whether technological or educational. And he's the president of the Hellenic Biomedical Technology Society, the International Society of Applied Neuroscience, and member to several other organizations. I would kindly ask anyone to read the bios of each panel member because they have a very large CV and very rich CV. Second, Stanimir Hasardzhiev. Mr. Hasardzhiev should tell us which patient organization he is not member in, because I see that he is a member and a distinguished member in so many organizations that I don't think that I need to read all of them. But the thing is that he's very active in patients' rights, patients' advocacy, and he's member or he has created or co-created several organizations that support patients' rights. And this is very, very valuable, and I'm going to ask the first question to Mr. Hasardzhiev. Are you a physician, by the way, or not?
Actually, I have a medical background, so I graduated in medicine, even though I've never been physician in the clinical
Never mind, so
sense
it's
of it.
Dr. Hasardzhiev then.
Yes, I'm a doctor by
Okay.
training, and by destiny, I am someone who dedicated his life for patient rights and exploring this brand new field of how we can engage and involve patients into everything concerning their health. So patients' involvement is and the patient report. The fields that I'm interested in, and of course, most likely, how we can change policies so they can serve better the society and patients.
Excellent, thank you very much. Now we're moving to Monica Gorgulo from Brazil, I assume. She's a clinical psychologist. She has worked quite a lot in harm reduction concerning alcohol and drugs. She has served as an elected president of the Brazilian Harm Reduction Network and in the executive committee of International Harm Reduction Association, an association that is not very active in the field of tobacco harm reduction, but it is extremely active in all other fields of harm reduction concerning drugs and alcohol. I think we should engage with this association because it's very relevant to our own goals. She has founded an NGO, Dinamo, Reliable Information About Drugs and Related Issues, I suppose in Brazil, right? So she's very active in harm reduction, not in the field of tobacco harm reduction, but we all know that harm reduction is a principle that is applicable to anything, including daily activities. And finally, last but not least, Dr. Enrique Rios Espinosa from Mexico. My latest publication was an analysis of the 90,000 COVID cases in Mexico. Dr. Rios is a senior executive for several years in the health and health regulation sector. He has served at the National Institute of Nutrition of Mexico. He has served as a consultant for the Ministry of Health, providing technical advice for health care reforms and for the development of regulation in several health-related sectors. He has worked in the private industry, food industry, pharmaceutical industry. He has published a lot of books. Have you ever worked for the tobacco industry?
No, I haven't.
No, okay. It's important for the audience to know, not that to me at least it doesn't matter, everyone is entitled of an opinion, but for transparency purposes. So I'm going to start with Dr. Hasardzhiev, and I'm going to ask something. According to the WHO, smoking is a disease. So smokers are patients. Can you tell me your opinion about this approach, whether you consider that to be a good approach, I mean an appropriate approach, the correct approach of addressing smoking, and what do you think about smokers considering themselves as patients? Do they do that? Do they feel that they are patients, and how does it work?
First of all, I need to disclaim something. I'm an ex-smoker, a very heavy ex-smoker, someone who started smoking during my teenage years, somewhere around 12, 13 years old. And I have been smoking almost all my life. And 2 years ago, after many attempts to quit smoking, obviously all of them been unsuccessful, for various reasons. We can go into that deeper, why people continue smoking. I actually nowadays consider myself as non-smoker because of the new combustion products, because this gave me opportunity to get rid of what I really know was killing me every single day. So I'm here to represent those who are affected, and one of those who felt guilty every time, every next fail when I had an attempt to quit smoking. In medical terms, smoking at the end is addiction, and all the addictions are well listed and documented to be diseases which require proper care and proper measures to support the people who are affected by any condition. But what I see from the institutions, and especially I'm very much surprised of the reaction of WHO, instead of providing the necessary care, understanding, and support to the people who are affected and addicted to smoking, and actually, instead of using and exploring all opportunities that nowadays we have with the new non-combustion products to reduce the harm on these people, to understand better why some of them never succeed in their efforts to quit smoking. Up to now, we see huge resistance from those who are actually introducing the harm reduction strategies in other addictions. I think that this is a matter of time at the end for them to understand that science cannot be argued, but also they have to understand and hear the voice of those, the consumers, and those who are affected by this addiction, those who are left alone right now, unlike the claim of many international institutions, especially Europe and WHO, saying that nobody should be left behind. On practice, it's the opposite. Those who cannot quit smoking are considered as the lost population, and I don't think this is the case. And that's why I'm here, because I believe that people like me have to have the chance to know that there are alternatives, and have to have the chance to receive proper care, to receive proper advice, to make their own choices.
You have expanded quite a lot and quite beyond my question. So let me wrap it up because I want to also ask the same question to Dr. Gorgulo before saying my own opinion. So to wrap up your response concerning my question, you consider that since smoking is an addiction, so, and we have a definition of addictions as a disease, that it is an understandable, let's call it. It's very hard to judge and call it right or wrong. It's an understandable or acceptable, let's call it, approach to consider smoking a disease. Am I right?
Yes, even though smoking, in a sense, is a reason for many other diseases. So sooner or late, I mean, smokers, in any case, would become patients. All of us would become patients.
But I'm talking about smoking as a habit, whether it should be a disease, because smoking is considered a disease irrespective of comorbidities that may or may not be caused by smoking. So that's your opinion.
Addiction is a disease.
Yes, okay. So what about Dr. Gorgulho? What do you think about this? Is it the right approach from the authorities, and mainly from the WHO, and everyone else is following the WHO, to classify smoking as a disease based on the addiction or based on anything else you may think?
Yeah, I think that we have to make the difference between addiction and even abuse. I think that there is a use, abuse, and addiction. So if we are talking about abuse, I think that we are not able to talk about disease. If we are talking about addiction, so then it would be, I think that is a good solution to call that a disease. But I think that we have many different ways of dealing with a disease. So I don't know if you, Professor, want me to keep on talking about this now or later?
No, we're going to talk later about this, but you can give us your insight on what a smoker thinks when he's healthy otherwise, so that he doesn't suffer from any disease, whether smoking related or not, and he listens to a physician telling him that you are smoking, so you are a patient and you need to be treated medically, otherwise you will remain a patient. So from a psychological perspective, what do you think?
Yeah, no, I think that this is, it can be a mistake many times, because we know that when we work with addiction, we have to make the user part of the process of the treatment and the find of the solutions and then etc. So when we call them patients, I think that we give them a place that it's not as active as it could be and have to be. Like when we call them, clients or something like that. So I don't know what word we could use here. But I think that we have to be very careful about this title of patient, because it can bring many confusions in the process of dealing with this. And especially because I think in my experience, and I'm sure that in your experience as well, we know how much contribution the users can bring themselves to the process of working with them to solve or to better address their necessities according to this use, abuse, or dependency.
Okay, thank you very much. I will admit that it's a tricky question on my side, but I'll be the last to present my views.
Okay, I hope we've passed.
No, it's not an exam. Don't worry. So, Professor Bamidis, you have worked on understanding how the brain reacts to various stimuli. One of the stimulus that someone may face as a smoker, but without any disease and feeling healthy, maybe he's a young smoker who still hasn't developed any disease, is that he will be called a patient. What do you think his reactions are going to be, his immediate or his mid-term reactions to that? Professor Bamidis. There's a problem? Okay, I see. And we can't hear him. So he's not online.
Thank you, first of all, for the kind invitation and the introductions. The experiences we have. Can you hear me?
We have some problems with the connection. I don't know if
Thank you.
if we can wait for a couple of minutes
Hear
or
me?
proceed. Now we can see
Hello?
you, Professor Bamidis. Yes, please.
Hello, can you hear me?
We are trying,
Okay,
yes.
first of all, thank you very much for the kind introduction. The experiences we have with regards to the free brain. We had different kinds of people involved in that. Although we had the usual patients with asthma and COPD and stuff like that, we also tried to tackle young unemployed people as a sensitive target group, as a vulnerable group. And the experiences we have, there is a kind of a reaction, and then their adherence to some kind of intervention or not depends on their kind of between a disease or towards a diseased state or not, if you see what I mean. So if they feel they are sooner or later going to become patients, they adhere. So it means that the brain is prepared in a way to react positively towards an intervention for smoking cessation. That's what we managed to sort of take out of some of the interventions that we have run.
So you are telling us that it's somatic disease that makes them more adhered to the goal of quitting, rather than classifying smoking as a disease, the addiction to smoking as a disease, while they are otherwise healthy.
Yes, I think so.
I will agree with you, and my opinion is that, of course, I agree that addictions are a disease, but we need to differentiate types of addictions. There are what we can call socially incompatible and socially compatible addictions. Smoking is an addiction that is perfectly compatible with daily social activities. People can drive, they can interact with people, with others, they can work, they can have families, they can work, they can be perfectly normal members of the society while they are smokers. So their addiction is not destroying their lives. They are, of course, it is, of course, causing harm, health harm. So it is very, very different from the addiction to, for example, opiates or alcohol, where which are addictions that are not socially compatible, basically, at least at some point, over some point. The other problem that we are seeing with harm reduction that is coming from the classification of smoking as a disease is that anything that can be used for people to quit smoking should be classified as a medication, because quitting smoking is considered a therapeutic intervention, and the classification of smoking as a disease is used as an argument to say that any product that will claim that causes smoking cessation should receive a medicinal approval. So, Dr. Espinosa, you have worked in the regulatory sector. How feasible do you think it is that products like alternative nicotine products, and I hope you're aware of e-cigarettes, for example, with a vast variability of different devices, different liquids and so on, how feasible do you think it would be from a regulatory perspective for all these products and all these different combinations to receive a medicinal approval in order to have a claim that they help people quit smoking?
Well, that's a very good question, Dr. Farsalino. Thank you for the invitation. Currently in Mexico, the Mexican Congress is trying to regulate these products, but what they are doing is putting into them as same as the conventional tobacco cigarettes regulation. They wanted to put them together. Now, Dr. Farsalino, if you allow me, since this discussion they told me I had like 5 or 6 minutes to talk about the smokers' rights on credible information. I would like to have an opportunity to speak my mind on that respect. Uh, and so this is very pertinent to our time in Mexico, because as I was saying, Mexican Congress is currently debating a reform to the tobacco regulatory framework aiming to impose the same restrictions of conventional tobacco, cigarettes, to all new technological alternatives for nicotine dispensing. It is imperative that smokers can access credible information about the existing alternatives that do not pose the known risk of exposure to smoke from tobacco burning for them to make informed decisions. The rights of an individual to honest, health, relevant information empowers them to be more in control of decisions regarding their health and well-being, and is based on the principles of autonomy and self-determination recognized in international declarations. The principles of autonomy and self-determination are also the basis of the concept of informed consent. Individuals cannot make autonomous, informed choices about their lives without pertinent and accurate information. Decision made, decision made in ignorance or based on false information will not reflect their true preference and will not allow real autonomous decision making. Providing high quality health information to smokers and to the public in general becomes critical when recognizing the public's right to relevant health information, since without it, they cannot make accurate health choices.
Wait, Dr. Espinosa, let's make it a debate. You will have a lot of time to present everything. Don't worry. It's not going to be a one question and then you will stop. So coming back, because I will give you the opportunity to discuss about that, because my follow-up question would be, if a product, which we are seeing in studies, or a group of products, we see that they help people quit, or they are used at least in the vast majority of cases as a smoking cessation tool. Since they don't have a medicinal approval, they cannot claim that they help people quit. And there comes the level of information that the smoker has. The smoker is not allowed to hear that there is signs showing that this product or this product group helps people quit, because it's not a medication according to the regulation. How big of a problem do you think that is? Because, for example, with electronic cigarettes, and we had a study that showed that it's twice as effective as nicotine replacement therapies. However, not being a medication, no one can use the claim that e-cigarettes help people quit, because this is a medical, this is considered a medical intervention to tell people that they will quit with something. So what do you think about that? Is that reliable, proper information? What can we do about that?
Well, that's precisely what I was aiming at. No, the problem is that they are not considering that as a device to stop smoking. They just consider them, they equal those devices as the same as tobacco products, and that they should be in the tobacco regulator framework. So right now in Mexico, the Congress is debating that they are going to put warnings and everything, and they are going to prohibit the importation of these devices into Mexico. And they are going to be more restrictive than as the same restrictions as selling conventional cigarettes. They don't realize that the studies that have been made, that they provide harm reduction of these products. They equate them the same as smoking. So they say they are equally dangerous than smoking.
Yes, I fully agree with you, and I'm pretty aware of the situation in Mexico. And I know that the climate there is not really favorable for these products. A question for Professor Bamidis and for Dr. Gorgulho. I'm a clinical physician, and I have a patient coming to my office, and I diagnose high blood pressure. So the only debate that I'm going to have with this patient is that I diagnose that you have hypertension, and I'm going to prescribe you a medication that can cause acute renal failure. And that's it, full stop. What do you think the reaction is going to be from the patient side? And would you think that he would be compliant or even accept to be prescribed the medication if I approach the issue in that respect?
Professor, is it another trick question?
It can be, because it will have a follow-up. Start with Professor Bamidis, unless we should be, pretty kind and allow ladies first.
Okay, but
Ladies first.
yeah, thank you, Professor Bamidis. Of course, okay, so many thoughts in my mind. I think that our culture has a very strong belief in the medical world. So it's in general what doctors say, it's taken as the best solution for whatever disease or bad things I'm feeling when I go to the doctor. But I think that prescribing the medicine to the high blood pressure maybe could make the patient accept it. But I think that it would be very important to the medical schools to teach and to train the students and the young doctors to the fact that this situation is wider than just some chemical arrangements. Because I would like to go back to what you said, Professor Farsalinos, that if there is a disease, so then there should be a treatment for that. But what the official voice says is that everybody has to stop smoking. So I cannot see that as a treatment. So when the patient of this person who made the question goes to the office, he's not there because of the smoking situation. He's there because of a secondary thing that he has because of the smoking situation. So when the doctor gives the patient this medication for blood pressure or something like that, there's no treatment for the addiction of nicotine. So we have to make sure that we put all the different actors together to work with this kind of situation. I will stop for now, but if I have time later, I can add something else.
Thank you very much. Professor Bamidis, would you consider,
Yes.
and I will clarify my question. I don't have time to discuss to the patient about blood pressure or the medication. I'm not going to tell him that the medication is going to fix his blood pressure and what's going to happen with him if he is left with a high blood pressure. I'm just going to present only one real side effect that may happen with the medication, and that's going to be the only information that I'm going to give them. And I will tell you why. Because whenever a patient, a smoker, sorry, for me it's not a patient, but whenever a smoker asks a doctor about electronic cigarettes, the problem, for example, the problem is that the response that they get is that it's not safe, full stop. There is no discussion about the relative risks between these harm reduction products and smoking. There is no debate about the real outcome of this approach, that the smoker will end up continuing to smoke. He will not end up a non-smoker, non-user of any alternative product. He will be a smoker after he leaves the office. The only information that they get, and I have experienced that personally too, many times, is that they are not safe, they are not recommended. And would you think, having worked in medical education and in information, how the brain reacts to information, would you think that this may even reach to a point of being medical malpractice in terms of science communication and dealing with someone who is at risk because of this habit?
That's a very crucial point, in fact, and I think yes, it could be, and we could end up with malpracticing at the end of the day if we don't pay special attention to developments or to comparative benefits, comparison of interventions and relative benefits and stuff like that. I mean, that's what current and contemporary research should be doing. I mean, we should be comparing approaches and we should be comparing benefits or reservations or side effects and stuff like that, and take decisions with the patient as with their active participation, basically. So I guess the cultural issue is still always on, how the patient would react to the doctor's advice or the prescription of anything. But I think we should get, all societies should get towards the culture of actively engaging the patient, the citizen, the person you have, the smoker, with the discussion of the relative benefits of XYZ approach. Otherwise, whatever the data are at the moment, or the decision we have, we might end up, in being wrong in a year's time when the data will be different, for example. So, yes, we could end up malpracticing at the end of the day.
To be honest, I fully agree with you, of course, and I will expand a bit. Because, in my opinion, it's not only a matter of malpractice, but it's also a matter of ignoring a basic principle in medicine and public health, which is a risk assessment. What is the risk? What's going to happen to the patient once I give him this information, or that limited information, or that one-sided information? No one seems to be thinking that this patient, this smoker, whether he or she is a patient or not, will leave the office maintaining his smoking habit. And this is harm by not providing, and I'm not saying that you should do the exact opposite, present these products as the miracles that will solve the problems and are not associated with any risk. I'm talking about providing balanced and reliable information and addressing what you said about the change in knowledge based on what we know until that day, until the day that we are seeing the smoker. So, Dr. Hasardzhiev, what do you think about that?
First of all, I think that people who are addicted to smoking and who are proactively seeking for help, they have no problem calling themselves either addicts or patients, because seeking proactively help on that means that you acknowledge very well that you have a problem and you want to get rid of this problem. And this was my personal case. Many people who have a disease, a chronic disease, and I'm representing huge patients organizations in Europe with chronic diseases. They know very well that smoking is not only a bad risk factor, it's something that's worsening their disease. And believe me, they're trying to find any way to manage with this situation as being patients and having main condition that in any case is killing them, and then having on top of that problem with cigarettes doesn't help them. On the opposite, it's worsening the situation, and many of the patients acknowledge this and they proactively seek help. Then going to a doctor and the doctor not being aware about the new data that we have, the new findings of science, which clearly show the benefits of non-combustion products in reducing the risk. I think this is the big problem, that in many cases the doctors are not well informed. It's really new. It's really revolutionary as a concept, as an idea, to help smokers by providing them with another tobacco product, even though it's with less, even no risk with very reduced risk for those patients. So I think patients have to have the right to have all information that they might need to make their choices. What's more, patients who have a chronic disease have to have the right to receive proper professional care and advice on smoking. It's not necessary this to be the cardiologist or the other specialist that is dealing with their primary condition. It might be someone else in the healthcare system to take responsibility and really to help this patient to go through the journey of reducing the risk or quitting smoking or finding the way to manage the situation. But it's not a solution only to tell the patient smoking is harmful for you, stop smoking. This simply doesn't help, and we have seen it enough. In Bulgaria, we recently launched and made probably the first survey and questionnaire among the smokers and non-smokers to see how they are, what is their perception on the new products and what is their perception on smoking and what is their perception on quitting smoking, etc. So very interesting results we found out. Many of the smokers consider smoking as a problem, regardless whether they know anything about the non-combustion products or not. So people are aware smoking is an issue.
Yes,
People with
let's try to be a bit shorter in our responses because we need to have some more questions, please.
True, but what I really wanted to say that the users, regardless we call them patients, and if they are patients already with another chronic disease, or they are patients only because they are addicted and consider them patients, or whether they're simply consumers who are healthy but know that smoking is problematic, they have the right to receive the knowledge first, and second, they have the right to receive the proper guidance and care to deal with this bad habit as it is qualified. And last but not least, I'll give you a small example. Obesity is also a disease, but we don't consider food to be treatment for disease. So we shouldn't make this direct analogy that it's necessary a product to be registered as medicine in order to be capable and able to help people to get treated for disease that they have. So if addiction is a disease, it doesn't mean that it's treated with medical products, the new non-combustion products, and they shouldn't go through procedure of medical products, not at all. But this is just a methodology that could be used to help these people, and it's our obligation to make sure that this methodology is recognized rather than entering into debates whether these are medical products or not. They are not medical products.
I will disagree with you, not with what you said. What you said was absolutely right. But I will disagree with you in the fact that it is illegal right now for any product that has not been approved as a medication to be to claim that it helps people quit smoking. It is illegal. So I agree with you that the reasonable approach is that you're using a change in behavior through the use of these products. They don't have to be medications. I fully agree with you with everything you said. But the matter of the fact is today that all over the world, no product can use a claim about smoking cessation unless it is a medication, because smoking cessation is a health claim. So in reality, it doesn't work. And coming back to my first question, what I'm going to say, and what's also my conclusion from your responses, is that classifying smoking as a disease and having the physicians treat a smoker as a patient and sticking strictly to the medicinal approach, which is you will either quit by yourself or you will use the medications, is in reality hiding information from the smoker.
Yeah.
Because the smoker is not receiving any information about these products,
Yeah.
although the physician knows and sees that the smoker has failed to quit with anything you provide them, or they receive misleading or biased, unbalanced information because the physician does not want the patient, the smoker, to use these alternative products, and the physician does not even think that they will just continue to smoke. So it's a bioethics issue, both in terms of what the smoker hears and knows, but it's also a bioethics issue against the physician with that kind of approach.
Yeah. Professor, can I add something to that?
Of course, of course.
Yeah. Yeah, I like very much what you're saying now, because things that I think, what is an accurate public health policy. So how can we say that we are doing a very good public policy if we hide many of informations that they are available everywhere? And before coming to this session, I had the chance to talk to some Brazilian smokers and Brazilian users of electronic devices. And they were telling me many stories of being guided by the seller, who of course just wanted to make money instead of giving them proper information. And they were telling me that there is no other way of trying to change from the smoke cigarette to electronic device, but going to a shop and then try to get information from the seller, because they don't have easy access to all of these informations that should be completely available at the service post offices, from the doctors' offices, and these sort of things. So I think that what you are saying is very important, because it shows us that we have to really work for having a real public policy related to burnt tobacco use.
I fully agree with you.
Let me say something, Doctor,
yes, of course.
if you may. Look, we have 17 million smokers in Mexico. How many of them do you think they go and seek advice from a physician?
None.
Very small. I don't expect you to have a number. A tiny bit. So I would like to address the problem of information, as you said in your title of smokers' rights on credible information, from a public health view, rather than a patient physician approach, because that will be minimal. No, we need to talk about policy making.
I fully agree.
That's what I'm going to say. The policymakers believe that being partial with the information, or not informing, or even deceiving, is justified to protect the health of vulnerable groups, in particular smokers and youth. There are some officials that consciously express support of non-truthful messages on new technological alternative for nicotine dispensing. The fear is that truthful comparative risk messages saying that these new devices are dangerous but are less dangerous than cigarettes could, one, make smokers to stop quitting in case they plan to do so, or encourage adolescents to use these devices and later start smoking conventional cigarettes, or increase nicotine addiction among the public. The logic behind these messages is that trying to scare children away from these devices by alleging that they are equally or more dangerously than conventional cigarettes are a constructed, even necessary public health strategy. This perspective represents an utilitarian ethical position where outcomes justify means when trying to achieve the greatest good for the greatest number of people. I think we should try to do the greatest good for the greatest number of people while also being honest and non-deceptive. Deception in health information is not an acceptable strategy. It's not proper even in the long run. So this thinking, common in many countries as in Mexico, goes hand in hand with the belief that government officials know what is best for their citizenship and justifies treating them as minors since they do not have the capacity to decide by themselves. Credible information on nicotine addiction should try to convey risks in a way that is meaningful to the public and that addresses the aspects of risks that are important to smokers. So that's what I'm saying. I mean, we should approach this as a public policy and a public health problem. That in Mexico, they say nothing about these devices and they want to prohibit them as not recognized as, but forget about recognizing them as harm reduction. They just put them in the same basket as a tobacco products, conventional cigarette smoking. That's what I think.
I couldn't agree more. I couldn't agree more with you that this should be a public health policy. And the only way that we engage with the policymakers is actually to provide what is missing right now and is their major argument, and this is data. And we are trying to collect data from, it's 2 years since we have the products on the Bulgarian market. And probably after this first 2 years, for first time, we really tried to collect the data from the users and try to understand what's going on. And we did this with 2 medical universities. And I believe we have now quite encouraging data to continue doing that and convincing the policymakers that at the end, this should become a public health policy rather than being kind of something that the doctor, based on his personal understanding, should be advising or not a patient to do. And widely, this information should be available for the public because people, citizens, users, patients, or regardless what we call them, have the right to have access to this information and to make their own informed choices. And this is something we have to do probably in future, to collect as many data as possible, to publish it in a way that it could serve the policymakers to make the right decisions, and also to be strong enough to insist that this becomes public health policies sooner than later. Last but not least, we have huge work to do with our colleagues, the clinicians, to get them on board, to understand what are the benefits of engaging with the patient and working with their bad habits as they consider the smoking, among many others like low physical activity or problems with the food intake, etc. But proactively to work with the patient or refer the patient to a specialist who can help the patient to the person to deal with the addiction to cigarettes and reduce their harm. I agree with you that many people wouldn't go to doctor, but they, at least for those people who would not go to doctor, we have to make sure they have proper information available, and that this is information supported by governments, and that the governments would incentivize actually the people to use products with reduced risk rather than stopping them entering the market. We had similar situation 2 years ago here. They tried to double the access taxes of the non-combustion products, you know, and to make them twice more expensive than normal cigarettes. Luckily, this did not happen in the country. So currently it's equal pricing at least. But it's something that we need to work together to address these issues globally.
Exactly. My whole point is that it is a human right to have access to credible information about harm reduction products to smokers.
Agree.
And that
absolutely
through a public health policy rather than patient-client or physician-client or physician-patient, because that will is very little, and physicians are not even aware of these products. So that's why they have to be a lot of dissemination, and that's what is the importance of it.
Professor, can I say something?
Yes, we will have a last round of comments, whatever you want to comment as a closing remark. I'm just going to remind everyone that it is a very small minority of smokers that ask for medical help in order to quit smoking, and this is universal. It is happening everywhere. It is even happening in countries like the UK, where smoking cessation medications are subsidized. And the reason, as far as Millie mentions here in a comment that he wrote as a member of the audience, smokers believe that smoking, and we have seen that in surveys of smokers. Why don't they go to the physicians, to a smoking cessation clinic in order to ask for help? Because they think that smoking is a bad behavior and a bad lifestyle choice, but not a disease. So since it's not a disease, according to the smoker, they don't need medications to quit. They need to change their lifestyle. And while the smokers think in this way, it's not a matter of simply of judging whether they think right or wrong. The problem is that we're not listening to them, and we are following an approach which is very different to their mentality. Not only that, but when our approach fails, we ignore addressing their mentality and providing them with what? With more alternatives. Because harm reduction is not going to substitute all the other methods of quitting. It will supplement them when they fail, and unfortunately, whether we like it or not, they fail in the vast majority, or they are not used by the vast majority of smokers. And this is the problem that I see of bioethics in terms of not only the smokers not having credible information, but what you said before, the end justifies the means, which in my opinion in public health is a disgraceful strategy. So on that note, I want to ask everyone for a closing remark, whatever you want to say without me asking a question, starting with Professor Bamidis.
I think what you mentioned earlier about medical products being all the non-conventional, so to say, smoking cessation is a very good point that should be actually emphasized more and more. We need all kinds of solutions to be considered like these, so that people, as well as professionals, of course, but also people can start believing in them. And definitely, as we discussed a minute ago, a generalized public health policy towards these would make sense. Otherwise, as you say, the actual smoker seeking advice is a very, very minimal percentage.
Thank you, Dr. Hasardzhiev.
The actual number of smokers who are seeking professional advice is really small, because the trust in the health system helping them, but judging them is not good. If smokers had really good, accessible, understandable information about alternatives, if they had, as in many other cases, people that they can refer and talk openly about smoking, I'm sure that this will be different. And it's not necessary this to be the doctor. It's not necessary this to be the nurse. It might be someone else who have been successful in quitting or switching the harmful products to something else. But what I'm saying is we need structured way to introduce information, to introduce policies and encourage policies in the countries, but also to support people to do that. And what's more, in our research, actually, the main reason for people to start thinking about quitting smoking has always been health. Regardless whether they go to doctor or not, many of the smokers have been trying in the past to quit smoking, and the major reason for that is not societal issues. It's not because the doctor said so. It's because they consider smoking as a health issue and they want to get rid of this habit. And therefore, they have been seeking for information. They cannot find it in the doctor's cabinets. They try to search in the internet, but we need to provide the relevant sources for these people who are going to continue searching for this information, and we need to provide the proper support for them, and we need to provide the proper evidence for the policymakers so they can be more on board. Last, and this would be my last thing, yesterday I had conversation with one of the new European parliamentarians, and I think we have chances now to have quite a good number of supporters in the European Parliament to start talking on higher political level about harm reduction in smoking. And I will continue in the next month exploring these opportunities. I do believe we need to have this wider approach rather than professional conversations here, but we need to go further to the public and start openly talking about the results that we all know, because people have the right to make their own choices. I agree with that, and we have to provide them with this information in the best possible way.
Thank you. Dr. Gorgulho?
Yeah, Professor Farsalinos, I'll go to the conclusion of the paper I had written. Like Professor Espinosa, I prepared something to formally present it, but okay, now I have my chance. We all know that there are no easy answers for this challenge. It was my conclusion. But while we keep on designing our solutions based only in the so-called credible information, which I think is the official information, we will deprive both the users of accurate information from different areas of knowledge, but also the scientists, the policymakers, from the huge amount of observation and perception that users have already collected. So,
But,
thank you.
Thank you, Dr. Espinosa.
Yes, thank you. No, but you're just talking about quitting and medicine and changing, but there are a lot of smokers that would prefer to keep on smoking, but they don't want to quit.
Yeah.
And if there are devices available that are less damaged or less harmful, they have the right to know that. And they have to have the opportunity and the choice to elect these other less harmful devices. So not everybody wants to stop smoking. They would prefer to do it or whatever. So there's, based on current evidence, smokers have a right to information on alternative nicotine dispenses devices as harm reduction options that will reduce substantially the risk of death in this individual. So that's the right to information. And that's what we are not having, because they are demonizing everything that contains nicotine, which we know that nicotine is not harmful. It's not, it's not innocuous, but still is less harmful than smoking conventional cigarettes. So that's the right the smokers need to know, not only the smokers that go to see the physician, but all the 17 million smokers in Mexico and the millions of smokers around the world.
Thank you very much. I will finish this very interesting debate, and I want to thank everyone for their contribution by reminding that the Ottawa Declaration of 1986 by the WHO was about empowerment in health. And the main core of empowerment in health is providing to the people the right information and the tools to take their health into their own hands and improve their health. The WHO has failed miserably, and the medical community, in my opinion, until today, they have failed miserably in providing proper information, which means present the advantages and the disadvantages, the knowns and the unknowns for harm reduction, because we don't know everything, of course. But we are failing to provide a balanced information on what we know until today, so that we will give the information as a tool to the smoker to make an informed decision. Thank you all. I fully agree with Fares Mili. It's not about addiction, it's about removing the harm. The harm is not coming from nicotine, and since nicotine is a socially compatible substance, I would have no problem with anyone using nicotine for life if it's not killing them, in the same way that we have no issues with people using caffeine, the whole population using caffeine for life. Thank you very much, everyone.
We don't hear you. We can't hear the last.
They can't hear me. Can you hear
Yes.
me now?
Okay.
Yes, now.
Okay.
Yes.
So what I said, did you hear about the Ottawa Declaration of Empowerment in Health? Yes. So I just commented on a question by Fares Mili in the audience that nicotine is a substance causing dependence, but it's socially compatible with life and it's not causing harm. It's smoking that causes harm. So as I said, I wouldn't mind at all as a physician, and it's not even, in my opinion, a moral issue, to have people use nicotine for life if it doesn't cause harm, and nicotine we know is associated with minimal harm, in the same way that public health is not doing anything for caffeine, with billions of people using caffeine every day, because it doesn't cause health harm. So we shouldn't care about dependence on anything unless it causes health or psychological harm. Therefore, the issue is smoking, the issue is combustion, the issue should not be nicotine, and nicotine should become an issue only if we have no more smokers in the world. Thank you very much.
Exactly.
Okay.